Okay. Greetings. I am Anton Fakhouri from the Department of Orthopaedics. I'm a hand surgeon here to talk about mallet fingers. We have a very nice lady, Carolyn, who agreed to demonstrate this injury for us. We see mallet fingers quite commonly here in Chicago, namely for the 16-inch softball that we have here that not too many other cities have, in addition to the other sports such as soccer and football. So you'll be seeing these injuries on a routine basis, so you might as well know how to treat them. You'll be seeing two types of mallet fingers. There's what's called the bony mallet fingers and the non-bony mallet fingers. So allow me to draw this to demonstrate. And so if this is the distal phalangeal joint, you have the extensor tendon attached to the base of the phalanx, and then the flexor tendon that's attached to the base of the distal phalanx. This is the flexor digitorum profundus. This is the extensor tendon of the digit. What happens is that as the ball comes in and hits the tip of the finger, as a person anticipates catching it, they misguide it, the ball hits the tip, and then so there's a force going in that direction, and the extensor tendon, of course, in that anticipation is extending the finger. So you have one force going in this direction, another force going in this direction. What happens? You get a rupture of the tendon right off the bone. And normally what happens is that you have now a deforming force, namely the flexor tendon pulling down and no tendon pulling up. So you have a flexion deformity and what's called a mallet. In some instances, you might see something like this, where there is a fragment that's pulled right off the bone, which is called the mallet deformity. Here, Carolyn sustained a mallet deformity, a bony mallet deformity, as she was catching a football during a swimming pool party. And so this is a demonstration of the mallet. This is the ecchymosis that you often see. You have a flexion deformity. Normally we see it even more flexed than this. She will be unable to extend the finger. I don't want to hurt her here, so I'm going to demonstrate the examination that you should do for a mallet finger. First and foremost, we want to make sure that both tendons are intact. So the first thing we want to do is maintain the proximal interphalangeal joint in extension and ask the patient to flex this digit. Please flex, and that means that the flexor digitorum profundus is intact. And what we will demonstrate next is the FDS and make sure that that's intact. So we will hold the profundi of the adjacent three fingers. Since the profundi all have common origin, if I hold the profundi here, here, and here of all three digits, then the only thing that will be flexing this middle finger is the flexor digitorum superficialis. Carolyn, can you bend this finger? And you can see that's intact. Okay? And so as you can see, she's unable to flex the distal phalangeal joint as she bends the middle finger because I'm holding the other three profundi in extension. So now we know that it's the profundi and the superficialis of the finger is intact. We can look at the extensor mechanism and know that she's unable to extend this. Can you try to straighten out your finger? She's unable to extend the finger. Can you straighten out this one? So you can see that she is able to extend the finger. And you can see all the ecchymosis swelling. If we press here, she'll be very tender. I don't want to do that to her, but you should also press against the proximal phalangeal joint and make sure that she doesn't have a central slip rupture, which is another mechanism that can occur from a football or other sport injuries, where a central slip ruptures right off the proximal phalangeal joint. That will be a separate presentation. How do we treat this? After we determine that there's no other injuries, our goal is to just extend the distal phalangeal joint. What we often see is that a splint is applied for the entire finger. Sometimes we see one extending from the tip all the way to the wrist. We don't need to do that. In fact, they may extend and flex the proximal phalangeal joint right from the get-go. All we want to do is maintain the distal phalangeal joint in extension. So one option is to simply put aluminum splint, maintaining the finger in extension, and just put a tape at the level of the middle segment, like this. And then do the same like this. And this is all you need. And then in this way, she's able to extend and flex this joint. Can you bend this joint? Okay. So the other option is to, if I may use your this hand, is to wear something called stack splints. So all you have to do is apply this and then put the tape right at this middle segment. Small fingers are hard to maintain in splints. Sometimes we have to send them in, for custom-made splints. But that's the other treatments. You can use a mallet finger or a splint. Obviously, we'd like to see the patient within a few days, preferably within 2 to 3 days, so that we can make sure that they have the right splint. The treatment for mallet fingers is to maintain the extension of the distal flange joint full time for 6 weeks. Even if they were to shower, they need to keep that splint on. What they normally do is they remove the splint, maintaining the extension, dry the skin, and put it right back. The minute they bend the finger, they need to start from that point on for 6 weeks, because at that point they have disrupted the healing of that tendon back to the bone. They disrupted that process, and now we have to start all over. After 6 weeks of full-time use, we ask the patient to wear it at night for 4 more weeks, to wear the splint for part-time 4 weeks, and then after that they may discontinue splinting altogether. Even after the treatment is complete, generally there's some mild drooping. If it's mild, it's not a problem. If it's more significant drooping, it will be a problem that can lead to other functional problems, including swan neck deformity, where they have a hyperextension of the proximal phalangeal joint and flexion of the distal phalangeal joint. Or it can catch. If it's flexed significantly, it can catch as the patient reaches for the kitchen cabinet or for their pocket. This is the end of the presentation on mallet deformity.